Thank you, Chairman. Good morning, ladies and gentlemen. Today, my talk is about the percutaneous closure of the ASD and the VSD. What is the issue? So my talk is relatively simple compared to the previous two talks. So please be relaxed and enjoy. So the first one is percutaneous closure of the VSD. In closing of VSD, two issues. One is the complete AV block, and the other one is aortic valve damage. This first percutaneous closure of the perimembranous VSD with the device was published in 2003 using an APCIS PM-VSD occluder. However, its long-term result was not so good. Complete AV block rate is 5.7%, and in Toronto group, the rate is around 22%. It's very high. So abandon this procedure, and also AV block may happen in 3 years after the percutaneous closure. So we cannot predict the occurrence of the AV block in percutaneous closure of VSD with using this device. Some doctors tried steroid therapy to treat the complete AV block. However, reappearance of the complete AV block was also reported. In comparison, the surgical result in PM-VSD closure, in 4,400 patients, 48 patients need pacemaker implantation for AV block. So this is the heart specimen on the right ventricular side. It's perimembranous VSD. Muscular VSD has no problem about the complete AV block. The perimembranous VSD is a problem. In the left ventricular side, the PM-VSD here. This is the right side, open, interarterial septum, and the tragus valve, the coronary sinus. As you all know, the cohost triangle. Inside the cohost triangle, AV node is located, and it goes like this. And divide right bundle branch. And on the left ventricular side, right coronary cusp, non-coronary cusp, and this is a membranous septum. It comes from the posterior inferior side of the membranous septum. So the right coronary cusp, non-coronary cusp, membranous septum, that comes from here. This is slides from the Dr. Jung Seo. It's the LV side, right coronary cusp, non-coronary cusp. It's the membranous septum. He dissects A, B, C, D, E, and we can see his bundle on D. D means posterior inferior side of the membranous septum. So this is the membranous septum, and his bundle course is the posterior inferior side of the membranous septum. So this is the APCIS PM-VSD occluder. It has two discs. The left ventricular disc has no superior rim. Instead, it has a long inferior rim. And then this is the right ventricular disc. So the shape is asymmetric. So when it was implanted like this, so there's the LV disc, RV disc. As we can imagine, this is the ventricular septum, upper margin. So his bundle is maybe around here. So the mechanism of AV block is, the first one is a direct compression. So this is the memorable alloy. As time passes, the RV disc and the LV disc squeeze. So the AV block can occur. And the other one is the inflammatory reaction or scar formation in the conduction tissue. So in case the steroid may work well, and this is the aortic valve, right coronary cusp, it did not touch. This is the echo, LA-LV, and there is a VSD, and it has aneurysmal change. So the LV side is large, and the right ventricular side is relatively small. it looks like PDA. Looks like a PDA. So this is LV angiogram, LV, and the aneurysmal change. LV side is very large hole, but on the right ventricular side, there are small multiple holes. So when we use the cocoon device like this, the device is inside the aneurysm, though we do not have to worry about a complete AV block because his bundle is here, no trauma at all, and the device is far away from the aortic right coronary cusp. So when we use the amplatous septal occluder, we can imagine on the right ventricular side, RV disc cover this area, and it may compress the AV bundle. On the left ventricular side, the left bundle branch comes here, and also it the device touched the left bundle branch. So I used the amplatous ductal occluder instead of the perimembranous PM-VSD occluder. If I use the amplatous ductal occluder, it has no right ventricular disc. So on the right side, don't worry about the touching AV bundle. And on the left ventricular side, the area of touching left bundle branch is much less than when you use the compared to the muscular VSD occluder. So this is the PM-VSD with the aneurysm, and I close it with the amplatous ductal occluder successfully. And I report it to the one journal. Oh, next one is issue is aortic regurgitation. Recently, I experienced a very interesting case. This is an adult patient who has muscular outlet VSD, aortic valve, and there is VSD. The moderate shunt was observed, and I measured left ventricular side diameter is 9.7, and the right ventricular side is 6.8. So I first used the 8mm cocoon device, but it slipped to the right ventricle. Before that, I checked the aortic regurgitation, and trivial aortic regurgitation was observed. And the LV angiogram shows the LAO view. And also on the lateral view, we can see the moderate VSD shunt. So then I changed the device to the 10mm cocoon device. But as you can see, significant aortic regurgitation was observed. But at that time, I'm worrying about the slipping again, so I cautiously opened the two discs. So this left ventricular disc did not touch the interventricular septum. So it may touch the right coronary cusp. And then I pull back a little bit more and withdraw the pigtail catheter. However, it still shows the significant aortic regurgitation. But I do believe this device may not touch the right coronary cusp, so I pull back more. Because as you can see, the right cusp, non-coronary cusp, and if there is a muscular outlet VSD here, there is some space between. So if I pull back more, it may not touch the right coronary cusp. So I pull back more, and then it attached the interventricular septum tightly, and the aortic regurgitation is significantly decreased. A trivial aortic regurgitation was shown. Then I observed more than 10 minutes. So in short axis view, also the trivial AR was observed. Okay, so I will show you the